This short video looks at the anatomy of the popliteal fossa. By the end of this talk, you will be able to describe the boundaries of the popliteal fossa, its contents, and the clinical significance of this region. So again, pause the video and see what you can remember about the popliteal fossa, particularly the clinical significance of the region. So if we look at the picture on the far right, we can see that the popliteal fossa is a diamond-shaped fossa to the back of the knee. The superior borders are made up of the semimembranosus and semitendinosus muscles medially and the biceps femoris laterally. The inferior borders are the medial and lateral heads of gastrocnemius. This larger picture shows clearly the large vessels and nerves that traverse the fossa. What is less obvious is that the floor of this fossa consists of the posterior surface of the femur, the fascia over the popliteus muscle, and the knee joint, the capsule of the knee joint. So there's not much between the fossa and the bony structures of the knee. If we look at the pictures of the right, we can talk about the important contents in more detail. So the popliteal artery is a continuation of the femoral artery into the popliteal fossa. It runs medial to the vein and the nerve, and it emerges from below the semimembranosus and semitendinosus tendons to run vertically down through the fossa. While in the fossa, it gives off the anterior tibial branch and then bifurcates into the posterior tibial and popliteal branches. The main nerve that traverses the popliteal fossa, which is this picture here, is the sciatic nerve. In the upper part of the fossa, as the sciatic nerve emerges from below the biceps femoris, it almost immediately breaks up into its two terminal branches, the tibial nerve, which then runs vertically down through the fossa and deep to the flexor muscles, and the common fibula or common peroneal nerve, which follows the edge of the biceps femoris and then runs deep to it and winds around the head of the fibula, then breaking up into the superficial and deep fibula or peroneal nerves. There are some important superficial veins of the leg which are related to the contents of the popliteal fossa, in particular the small saphenous vein, which forms just behind the lateral malleolus, runs up the posterior aspect of the leg, superficial to the deep fascia. It then pierces the deep fascia or the popliteal fascia and drains into the femoral vein, which is the vein that accompanies the femoral artery. So as you can see, from lateral to medial in the fossa, there is the common peroneal nerve, tibial nerve, the popliteal vein, and the popliteal artery. There are some other important contents here, which include lymph nodes, lymphatics, and some of the outpouchings of the knee joint, which we'll talk about in a little while. So let's think about clinical correlates. So these important deep structures are at risk of injury, and we kind of need to know the structures to know what could happen when there are serious injuries to the knee or structures around the knee, particularly in relation to knee dislocation, supracondylar fractures of the femur, and compartment syndrome. The vessels and nerves in the popliteal fossa are at risk of injury, and this is why these injuries can be neurovascular emergency. So you can take the time now to think about the clinical features that may present in patients with injuries to the tibial nerve, the common fibula or common peroneal nerve, and the popliteal artery and popliteal vein. So outside of injury, there is another important clinical correlation we need to think about with the popliteal fossa, which is when a patient presents with a swelling to the back of the knee or swelling within the popliteal fossa, we need to have a differential diagnosis for this, and actually the anatomy tells us what we should be looking for. So there are many structures there that can cause swelling. We can start with vascular structures, so you might get aneurysms of the popliteal artery or vein, which will present as cystic or pulsatile swellings to the back of the knee. There may also be swellings due to enlarged lymph nodes, or swellings due to outpouching of the synovial sac of the knee joint. Typically, this is seen with the Baker's cyst. The Baker's cyst is a posterior outpouching of the synovial cavity of the knee joint, which is in communication with the knee joint. Therefore, it may be present when the leg is extended, but may disappear when the leg is flexed. Other swellings of that area would include injuries to the gastrocnemius muscles, thrombosis of the popliteal vein, and tumors of the soft tissue around the knee. So that was a very brief look at the popliteal fossa. If you have any questions, you may bring them up in class. In summary, we looked at the boundaries, contents, and clinical correlation of the popliteal fossa. I hope you found the talk interesting and useful. Thank you for listening.